So I've become much more cheerful. But do I actually think we can get world peace from from doing this? No. Am I giving you a depressing answer? Or?
No, not at all.
Yeah, I mean I have some limited expectations. There was another question that Mm-hmm. Yeah, I mean, one of my favorite examples of that is looking at the provision of antidepressants for the treatment of postpartum depression in women. So this assessment is typically done. We say, right, should we as the insurer cover therapy or medication for postpartum depression, let's say? And usually this calculus is done based on an assessment of the costs of the treatment, how much money it costs, and the risks to the woman in this case in terms of side effects of the medication and the like. And then the benefits are, well, her increasing happiness, her mental state, her returning to work sooner and the like. But what if I told you that taking better care of moms by treating their postpartum depression better makes them more likely to vaccinate their children or treat the kids' asthma better, and that we can reduce asthma in children by providing better health care to mothers? Not only is that an optimal outcome from the point of view of society, I mean, that's a good thing. Now we're getting much more value, bang for our buck, in spending money on the woman, treating her, but also from the insurer's point of view, if you're thinking about an insurer who typically has a whole family that is within the insurance company decision makers, say, oh my goodness, this intervention is actually much more cost effective and reduces the healthcare consumption by my beneficiaries if I actually provide it. So, or if you're debating whether or not to, for instance, pay for a hip joint replacement, and you're just deciding, well, it's not quite worth it because the quality adjusted life years that the person gets from replacing the hip is X, but now I tell you get 2X because the person's spouse also benefits, you might change your calculus. So that's one narrow way in which I think it might be relevant. Oh my God, that's a very good question. So, and this is one of the provocative results that I didn't highlight when I showed the last slide. So here's the argument. When organ transplantation was just invented in the 50s, many of you may know this and some of you may remember it, organs for transplantation were very scarce, and there were these sort of kidneys in particular. And in fact, dialysis machines were also very scarce. And committees were made up, these so-called God committees, that would decide who would get the scarce organ and who would get the access to the dialysis machine. And those committees at the time used to take into account whether someone was a family man or not. So if the guy was a family man, then he got preferential access on the grounds that he had a family to support. And this was ultimately seen as unethical. This was seen as unjust and not right, and that we shouldn't privilege people who were supporting families over others who were not. And this standard was done away with. It actually crept back in a way that Renee Fox documents in her wonderful book, Courage to Fail, and her book Spare Parts about organ transplantation. This notion crept back in the other guises. But here's my point. If you take seriously what I'm telling you, it means that actually we should do that. It means that when we're allocating scarce resources, we should preferentially give them to people who are more connected. That's very provocative, actually. And I'm not making that claim because I'm troubled by it, and because I have other things I need to do. But if you take it to its logical conclusion, you might be led inescapably to that claim. So risk pooling, I forgot how I got onto that point. Maybe I was responding. I don't know. Okay.
We'll take one more question.
Yeah, okay.
I just want to let everyone know that we have an exception of time.
Okay, cool. Yes.
What I've been hearing about are a lot of good things.
That spread, yes.
They can spread. It just occurred to me.
Bad things can spread.
Look at things the opposite way.
Correct. That's right. Depression can spread, or a tendency to abuse prisoners can spread. So if you're in a network of people that are abusing prisoners, then you might copy the prison abusing behavior of the people around you. There's no doubt. And this touches on this whole free will thing that I alluded to earlier. Incidentally, everything I discussed today is symmetrical. So just as obesity can spread, weight loss spreads. Just as smoking cessation spreads, smoking uptake spreads. Just as happiness spreads, unhappiness spreads. And what determines the overall kind of trend is what's sort of rising within the population. So although both obesity and non-obesity spread, we are looking at the period of time when the whole population is gaining weight. It's a kind of period in which obesity is winning out, as it were. And this actually touches on another very subtle thing that I kind of blew by, which is that what our work, all the stuff that we did can't explain how epidemics start, right? They just explain how they are sustained. So something else has to start weight gain. Like even if you buy the whole patient zero analogy, if you had this fabric of people who are all normal weight, and they're all influencing each other, until something else exogenously causes one person to gain weight, or stochastically, someone randomly gains weight, then you can't have the epidemic. And actually, if you think by analogy to epidemics of germs, if you have a population of people on an island, they don't get a syphilis epidemic. Someone has to bring the syphilis to the island, and then it can spread within the network. You see what I mean? So both good and bad things can spread, and our results don't explain how things get started. They just help explain how things propagate. Thank you again.